Hey, so I did my presentation on PTSD, and I'm going to start with saying my two PANTS questions. So, number one, a 24-year-old female presents to your clinic for a routine well woman exam. Upon examination, you notice bruises on her thighs and a positive chandelier sign. When you ask the patient about the bruises, she cannot recall any recent events. Her mother claims that over a month ago, her boyfriend sexually abused her and claimed that he was going to kill her because she cheated on him. The mother informs you that the patient has been having recurring nightmares about the event and avoids talking about it in conversation. She also notes that the patient has been drinking a bottle of wine every night since the event, has been extremely irritable, and recently refused to interact with men. What is the most likely diagnosis? And it's PTSD. So, question number two. 3 months after returning from Iraq, a 35-year-old male veteran presents to your VA clinic complaining of recurrent nightmares that encompassed a previous bombing experience 4 months ago while he was on duty. The veteran reports avoiding video games and other life events that involve loud noises or contain warlike themes. He also notes that he has severe anxiety during thunderstorms because the noises remind him of noises that were made in Iraq. Lastly, he points out that he has multiple recent anger outbursts and gets startled easily with loud, unexpected noises, and that he avoids crowds for safety. After acquiring a thorough history, you make the diagnosis of PTSD. What is the first-line therapy for this patient? And the answer is escitalopram, which is Lexapro, and SSRI, which is first-line medical therapy for PTSD. So I'm going to present my patient. He was a 28-year-old male veteran that reported to the Lufkin VA. He has past medical history significant for post-traumatic stress disorder and major depressive disorder. He currently takes trazodone and Prozac. Today he complains of recurrent nightmares about a grenade that was thrown into a room where he watched all the women and children die that were in that room. He claims that these nightmares have been sparked by his 10-month-old daughter crying in the middle of the night. He also complains of extreme tiredness in the morning, which he thinks is because of the trazodone, and he's inquiring about a medication change. Today, he denies any anger outbursts, any irritability, headaches, nausea, suicidal or homicidal ideation. So current medications, he's just taking Prozac 10 milligrams PO QD for depression, anxiety, and PTSD. He's also taking trazodone 25 milligrams PO at bedtime for sleep disturbances, and he has no known drug allergies. On physical examination, patient is pleasant, he's ambulatory and no apparent distress. He appears his stated age and he's dressed casually. His mood is good and his thought process is logical. His vital signs are stable, he's afebrile. For psychiatric, his content is negative for suicidal ideation, no delusions or hallucinations. His insight and judgment are fair. He denies hopelessness and his affect is mood congruent. And for neurologic, his mental status, he is alert and oriented ×3, and the cardiovascular, chest, abdomen, and extremities were all deferred, and he has no labs. Assessment, so number 1 is post-traumatic stress disorder unspecified, and number 2 is major depressive disorder, recurrent and moderate. So the plan is to continue his medication regimen as well as therapy. He is consulted. We've consulted the psychiatrist for a medication change, possibly. Patient education, so he is educated on the medications that he's taking and their side effects. He's educated to call 911 or the suicidal hotline for any suicidal or homicidal thoughts. He's given the clinic phone number for any questions. He's instructed to avoid alcohol, drugs, tobacco, or guns while he's on this medication, and he's educated not to drive or operate heavy machinery due to the sedating factors of the medications that he's on. He is ordered to return to clinic in 6 weeks for a follow-up with the psychologist. So now I'm going to present my disease sheet. So disease, process, and condition. PTSD is an exposure to a traumatic event, an actual or threatened death, and a response which may involve helplessness, avoidance of associated stimuli, emotional numbing, and increased autonomic arousal. The etiology and epidemiology, so PTSD is most common in young adults. It's a response to a catastrophic life event in which the patient experiences trauma. Trauma can be in many forms such as combat, violence, assault, child sexual abuse, disasters, ICU hospitalizations, and even severe physical injury. So the anatomy and pathophysiology of PTSD is secondary to alterations in the amygdala and the hippocampus. So the emotional center of the brain is the amygdala, and then the memory center is the hippocampus. Both, when stimulated, can lead to the stress response and eventually long-term anxiety. The amygdala processes new information, causing the information to be accessed quicker in forthcoming encounters. This organ activates the hippocampus to create new memories specific to this fear, which leads to the re-experiencing and the hyperarousal seen in patients with PTSD. And also note that olfactory and tactile stimuli bypass the thalamus, going straight to the amygdala, which causes an increased emotional response and heightened memory response, more so than visual and sound stimuli do. So clinical signs and symptoms: there's survival, guilt and irritability, poor concentration, amnesia, personality change, sleep disturbance, re-experiencing events such as dreams, avoidance of associated stimuli with the trauma, numbed responsiveness or anhedonia, as well as increased arousal such as hypervigilance, and then exaggerated startle response. So the diagnostic criteria is A, the trauma is re-experienced over a month from when it happened as recollections or dreams or acting as if the event's recurring, and avoidance of related stimuli, thoughts, and or conversations. They also have to have 3 or more of the following: inability to recall an important aspect of the event, avoidance of activities surrounding the event, attempts to avoid thinking or talking about the event, feelings of detachment from people, marked decreased interest or anhedonia, a restricted range of affect, belief that one's future has been shortened due to this event, and then an increased state of arousal characterized by 2 or more of the following. So it can be insomnia, irritability, angry outbursts, decreased concentration, hypervigilance, or an exaggerated startle response. Some complications of PTSD: so there is comorbid depression, as well as substance abuse and somatization, which are common, and then less likely is going to be suicide or suicidal ideation. The biggest complications are the side effects to the medication. The side effects of the SSRIs is going to be diarrhea, nausea, sexual dysfunction, and headache, as well as serotonin syndrome. Side effects of TCAs are going to be all the anticholinergic problems with sedation, dry mouth, constipation, and weight gain, as well as agranulocytosis. The side effect of MAOIs is that the overdose is lethal, and you can also have hypertensive crisis. And then, so the prognosis: so 50% of patients remit their symptoms when they are treated for 3 months. And if their symptoms are less than 3 months, it's considered acute. And if they have symptoms progressing longer than 3 months, it's considered chronic. And if their symptoms are more than 6 months after the event has occurred, it's considered late onset PTSD. So management: first line medical therapy is SSRIs, and then the second line is going to be TCAs or MAOIs. First line non-pharmacologic therapy is cognitive behavioral therapy. The psychotherapy can be individual or group, and then crisis counseling should also be implemented as a preventative measure. Some alternative treatments are hypnosis, coping mechanisms, and relaxation techniques. And then also buspirone. Since comorbid substance abuse is very common with PTSD, buspirone is good because it does not potentiate the effects of alcohol, so it's great in treating anxiety in patients abusing alcohol. Also a good choice for those with PTSD. That's it.